Welcome to our webinar, Thinking Strategically About Subgroups in ITC. This is the second in our series about subgroups and indirect treatment comparisons. My colleague Casey will take us through the content in a bit. Firstly, I'm just going to go through 3 or 4 setup slides. First, some housekeeping though. We encourage questions throughout the webinar. Please feel free to submit them on the right-hand side of your dash panel that you should be able to see on the screen. At the end of the webinar, we will answer these questions. If we're unable to address all the questions, we will get back to the individuals through emails at the end. As I said, this is the second part of our series. The first webinar talked about developing informed strategy for subgroups. Anybody who missed part 1 of the series can email us, either Casey or myself, to provide a link to the video. The key conclusions from the first webinar focused around seeing subgroups as a potential opportunity and preparing for the HTA reality of subgroups early and also making informed trade-offs. We suggested that this can potentially lead to commercially better P&R outcomes if done appropriately. Subgroups are obviously a key part of the market access landscape that we deal with every day. And this slide highlights some of the other key emerging trends from a market access perspective, which have been the framing for a lot of our webinar series. This component, the subgroup component, allows manufacturers to think and support a stronger and more evidence-based value proposition. Of course, we cannot view subgroups in isolation, and we'll discuss some of the interdependency across these themes throughout the webinar. As we look at the payer landscape and payer archetypes, some of these payers have different objectives. So in the UK, subgroups are used to manage uncertainty. In Germany and France, they're used to link through to cheaper alternatives, to dilute your value proposition and to ultimately inform pricing negotiations. And we'll talk about a number of these different scenarios as we go through the content. As with the previous webinars, the framing for the content is the actual questions and requirements covered within the HTA and P&R submissions, as well as the underlying methodological guidance. This framework, called the PRMA Health Check, is a cross-functional, collaborative, interactive strategic planning tool which ensures your market access HUR strategy is grounded in the country-specific HTA and P&R submission requirements. With that introduction over, I'll hand over to my colleague Casey Quinn to take you through the rest of the webinar. Thanks, Casey.
Thank you very much, David, and thank you everybody for coming along. For those of you who were here at the last webinar, thank you very much for coming back. Just quickly in terms of the contents for today, David's just been through the recap from the last webinar and some introduction. I'm going to briefly go through the HTA challenges that come up with subgroups and indirect treatment comparison, and then the main part of today's talk will be the challenges that arise, and I'm going to present those within illustrative scenarios that will help us dig into the nature of these challenges and what they mean for us and what they mean for manufacturers, how we can attempt to get around them, and then discussion and conclusion as usual will be at the end. And as David had said, please ask your questions during the webinar and that will be passed to me to discuss at the end as well. So first, briefly, the HTA challenges with subgroups and ITC. And the issue to bring up at the start is that there's not an obvious connection between these. The subgroup aspect of these challenges and the ITC aspect of these challenges don't actually coexist. There aren't published methodological requirements that simultaneously address each of these. Instead, what you find is there are requirements for subgroups that can pertain to ITC, and there are requirements for ITC that can pertain to subgroups, and we need to figure out that intersection. What is more common for us to see is that it's subgroups that get picked up upon most and typically first, and we saw this discussed in the previous webinar. And so what we're going to talk about today is the contingency within that of ITC. So I had this last time as well, and I'm not going to go through these in detail, but these are just some of the stylized agency requirements for some certain countries. Germany is an obvious example of this. Everybody listening should be familiar with subgroup-based challenges with the GBR, indirect treatment comparison-based challenges with the GBR. These are all listed in their template for Module 4. Generally, the focus that you see in Germany is on the impact of subgroups and the way they isolate comparators and the impact of that on relative treatment effect. And I'm going to talk about this as a bigger concept in a moment. Australia, PBAC, and NICE in England are slightly different examples. These are examples of countries that have quite a lot of prescribed requirements methodologically, but they're typically more forgiving in the face of data challenges. But at the same time, they will stop at a certain point in their willingness to accept methods, and this has to be borne in mind. But PBAC and NICE are a good example of agencies that have a broader net, and when they think about these issues, they think about them from first principles. What are the assumptions that underpin your analysis? Do those assumptions hold? And in the case of ITC, do they still hold with subgroups, or are they broken? The US, I talked a little bit about last time as well, and I want to make the same point here. The US is not excluded from this consideration. It's not excluded from a list of countries where these challenges are relevant. The US is interesting from a little bit of a transparency point of view. They have quite a lot of recommendations linked through to things like the ISPOR Good Research Practices Guide. And I think you could reasonably say that in the US there are published expectations for these methods without those things necessarily being requirements. So coming back to NICE, what I've listed here is from the NICE Guide to the Methods of Technology Appraisal. I couldn't outline all of the NICE recommendations because they literally spread across multiple documents. They're in the guideline for the methods of technology appraisal. They're also spread across a series of technical support documents that are published by the NICE Decision Support Unit. But NICE is an interesting example, which we're going to come back to later. Although they have an envelope of methodological requirements, what you see a lot in agencies like NICE is a willingness to accept novel methods that surpass that envelope. If those novel methods are appropriate to the circumstance and well justified, those will be accepted. So that's another factor that should be considered when we're planning our evidence generation. Keeping with PBAC and NICE though, this is sort of the starting point for what we want to get to, which is a lot of these methodological requirements that are published, a lot of our discussions tend to be very subgroup specific. What we find at PRMA Consulting with our clients is a tendency for evidence generation to go through the process for an overall patient population of establishing the best approach, then dealing with subgroups. The argument that I'm going to make today is that, as it says in blue, the evidence for the subgroups and indirect treatment comparison should be considered as though it's freestanding. In the case of confronting subgroups, those should be treated as though they are the indication. And this is relatively straightforward to do for a bunch of agencies. Here I've got the PBAC recommendations for evidence synthesis, and you see it's essentially a hopscotch game of decision making and which approach you're going to take. That approach shouldn't be taken once and then returned to retrospectively. Ideally, that approach would be taken for each subgroup and the decision made for each subgroup about the best method. And as I alluded to before, the NICE Decision Support Unit, amongst their published support documents, is a checklist. Well, this checklist is the sort of thing that could be redone subgroup by subgroup to the same effect. And obviously, it is not going to be optimal to do this for every subgroup. There's going to be some compromise between never doing this and always doing this. But the key point that I want to make is that it's not the delta that should drive subgroup considerations, it's the strength of the evidence. And this is where the ITC considerations become relevant. So with that sort of introduction in mind, I want to pick up on the nature of the challenges that arise. And this is an important thing to translate. As I said at the start, ITC and subgroups are effectively two different frameworks for analysis and assessment. You can think about ITC fundamentally as being about making as similar as possible the things that moderate treatment effect. And that allows closer and more direct comparisons between otherwise unconnected drugs. On the other hand, subgroups are fundamentally about reducing uncertainty in the measurement of clinical and cost effectiveness, and this means weakening the strength and the feasibility of ITC in the process. They can be completely orthogonal at times. And what's interesting about this is it doesn't much matter how you consider this behavior. On the one hand, we can treat payers as agents who are motivated entirely by minimizing uncertainty. Payers are uncertain about the information they've got. One thing a payer does know is when he or she says yes to a submission, they're unlikely to get any more evidence. If he or she says no, maybe they will get more evidence. Subgroups are a very blunt way of trying to narrow that gap and reduce the uncertainty. So if you think about reimbursement as this sort of game, the rationale behind payers as agents isn't materially different from, say, a more cynical view, which just says payers are all about subgroups because it affects the comparators and provides a very strong lever for price negotiation. From the perspective of the manufacturer in the same game, the payoff matrix and the strategies are almost exactly alike. And we're going to come back to the uncertainty issue in a little while. But I want to start the challenges by thinking about what I had said about NICE and the PBAC. We need a framework to talk about this, and at least for the next 40 minutes, this will be the framework for us. And like I said, there's no published guidelines for ITC with subgroups in inverted commas. What we can do is start with indirect treatment comparison and the assumptions that underpin indirect treatment comparison. What makes indirect treatment comparison strong or weak? And relatively simply, it's these three assumptions: homogeneity, similarity, consistency. Homogeneity assumes that across multiple trials, they are measuring the same treatment effect. That means that out there in the world, there is a true treatment effect of drug A on disease B, and there are multiple clinical trials that test this. If you synthesize them, you will get closer to the true treatment effect. Similarity says that the patient populations across those multiple studies are similar enough that they're reasonably exchangeable. You are comparing like with like. And consistency is more of a structural assumption within a treatment network for ITC, which assumes that if you were to take only the direct head-to-head comparisons of drug A versus drug B, if you were to take only the indirect comparisons of drug A versus drug B, or the combined evidence, you should get reasonably close answers for all three. You shouldn't have bias that your network has within it for unobserved characteristics. So these are all assumptions that need to be met to be reasonably safe to undertake ITC and have strong evidence. And then here is where subgroups come in. What we want to consider is, in the case when subgroups have been requested or are relevant, what impact does this have? Well, we can start at the top. The idea of subgroups is that they may systematically separate relative treatment effect. Drug A works systematically differently in one group versus another. It's first line versus second line, it's fit versus unfit. There are any number of qualifying factors. And this sets up the idea of the interaction between subgroups and treatment effect that has to be tested for. If one is found to exist, that has implications for how you can proceed. The similarity assumption is primarily affected via natural history. Obviously, subgroups are used a lot to identify varying unmet need. Subgroups are also identified a lot to identify different standards of care and appropriate comparator. And then consistency we're going to come back to because it's the interesting technical challenge that arises of these three. The presence of subgroups can affect the ability to undertake what's called adjusted indirect treatment comparison. This is the standard that's expected of most agencies, and it's when you adjust during your synthesis for variation in prognosis or variation in treatment effect. Different subgroups can prevent you doing that to an acceptable level. Now, how am I going to go about that? Like I said, I'll do it with scenarios. I have 3 corresponding with the same list. So scenario 1, we assume a subgroup affects natural history. My example for that will be Iclusig, which had 2 indications. Scenario 2, a subgroup will affect the standard of care or the included comparators, and I'm going to talk about Inlita for RCC. And then the third, like I said, is the interesting technical one, which is when a subgroup can affect the ability to perform adjusted ITC, and I'm going to use melanoma as a very good example for that. Starting with scenario 1, if we look at Iclusig, and in this case I'm using the Transparency Committee and Reimbursement in France, Iclusig was registered for CML or Philadelphia positive ALL who have the T315I mutation. What the Transparency Committee found was the actual benefit of Iclusig was important across these indications. The incremental additional benefit, the ASMR, however, varied. And it varied based upon CML and ALL with the mutation or not, and it varied between an ASMR of 3 or 4 or 5. And in all of these, this was based upon the comparative data. So it was the comparator in that group, it was the relative treatment effect in that group, and the natural history that underlay that, even though according to the SMR, that natural history, that prognosis, the unmet need was still quite pronounced. Now, I can illustrate this fairly simply. If we take, let's say, a classical survival curve, we have a drug and overall natural history. So this is the baseline survival in our overall patient population. And you can clearly see here the treatment effect. Now let's assume that we have subgroups, our green line and our orange line, that have variation to that natural history. So what we can see illustrated here, group 2 has demonstrably poorer prognosis, you would assume higher unmet need, than group 1, which has greater survival. What you'll see in the subgroups then for the analysis is if we assume that the overall treatment effect, the absolute survival for the drug remains unchanged, as a function of the natural history varying, so too will the relative treatment effect. And what you'll have going down this list in the blue boxes are the sequelae to this and what's going to happen. You see that benefit is greater in subgroup 2, you see that unmet need is greater in subgroup 2, but you see that relative treatment effect is going to be different even though absolute treatment effect remains the same. And what you're going to see in the next example, of course, is this green subgroup and the orange subgroup. Because of their different natural history and unmet need, we could find different standards of care. Getting down to the bottom box, what that means is that establishing relative treatment effect, establishing incremental clinical benefit, establishing incremental cost effectiveness is all still going to depend upon evidence synthesis and indirect treatment comparison typically. And in this case, it's going to now depend upon it in subgroups that are going to have to account for those factors. The second scenario is more specifically when a subgroup necessitates a change in standard of care or the included comparators. And I think this is the most immediate implication that people think about when they think about subgroups, that it's going to change the standard of care or the comparator. So like I said, the example for this is Inlyta for second-line treatment of stage 4 clear cell variant RCC. And in this instance, I'm going to use PBAC as our example. So this just has a brief timeline for Inlyta in Australia. It was TGA registered mid-2012. It was rejected after assessment by the PBAC in late 2013. It was recommended by the PBAC in late 2014, so after a year's delay. And the details of this are fairly interesting, not just in Australia, but around the world. And we'll pick up on a little bit of this in a later example. In the original assessment, the submission for Inlyta was rejected in second line. Interestingly, at the same time, Nexavar was also considered, i.e. in the same meeting, and they're effectively considered together. And this is considered to have had some effect on the strength of the clinical evidence given for Inlyta versus best supportive care. And the basis of that was, even while the assessment was restricted to second line in order to have some control over the standard of care to be compared against, i.e. BSC, there were still such significant differences within that group of the studies that were used in the synthesis to get best supportive care. Like it says here, some were trial characteristics, some were patient characteristics, that they didn't have strong enough evidence of clinical effect. What happened in 2014 was, in the intervening year, other drugs had been reimbursed. Sutent, Votrient, and Afinitor at that point were on the market. Afinitor was the relevant comparator in second line at that point. So Pfizer made a submission comparing Inlyta to Afinitor via indirect treatment comparison using Nexavar as the link. And that was accepted. And that was on the basis of a more novel method that I'll talk about in a little while called matching adjusted indirect comparison. The interesting thing about this is that outside of Australia, this was also accepted using the same approach to indirect treatment comparison by NICE. That approach to indirect treatment comparison was rejected by the GBI in Germany because it didn't conform to the prescribed methods that you find in Germany. Picking up on our last webinar, interestingly enough, Zedelig is a very similar example, and we talked last week, if you look at the central columns, about the experience that Zedelig had in the SMC, where Gilead were successful in requesting that they only be assessed in second line, where best supportive care was the appropriate comparator. Less so, again, in Germany with the GBR, when they were split into 5 subgroups, different natural history, different comparators. 3 of those subgroups didn't have the appropriate evidence. And this is another scenario which we can illustrate fairly simply. So if we think about a classical treatment network diagram, what we have here are essentially 2 different treatment networks. We have our drug at the center, and if we divide our market into 2 subgroups, first line and second line, you can see varying evidence. It appears stronger in first line than it is in second line. You can see that second line is reliant upon a connection via a clinical trial, a connection via an abstract only. But what we typically see, and this is where how you frame the motivation of payers can become relevant, this is a situation that's reasonably common. The selection of the subgroup can be such that those comparators in first line which had a stronger connection are not appropriate or not accepted, which leaves just the second line scenario. And the second line scenario now has much weaker evidence than the overall patient population would have had, much weaker evidence than the first-line only patient population would have had. And this is effectively entirely due to the selection of the subgroup. If you're the manufacturer at this point, you might find your evidence went from being reasonably good to completely unavailable. And that is a point that I'm going to pick up later as well. The third subgroup, which I wanted to get to, like I said, this is the one with the interesting technical challenges. What happens when the subgroup affects the ability to perform adjusted indirect treatment comparison? More than the others, this comes back to the point that I was making at the start. If you visualize this problem, in this case, I've drawn it as effectively orthogonal requirements. Down one locus, you have this idea that subgroups are predicated on the expectation of confounders or effect modifiers, i.e. things are different. Along the horizontal locus, ITC methodological requirements are under the assumption that you can bring confounders and effect modifiers together, or you can control for them such that you have similarity. And these two things don't easily coexist. And I think the canonical example of this right now is melanoma. And if you look at the slide here, I've essentially laid out the story of approval for treatments for melanoma in England and Wales over the last 4 years, more or less, beginning with Yervoy, Zelboraf, Yervoy again, and Tafinlar. And of course, there are more products to be assessed even in the next couple of months. It is a very fast-moving market. If you follow this chronologically from left to right, you can tell the story of how these issues arose. In the first assessment, indirect treatment comparison and subgroups, at least in NICE, weren't especially an issue because of the lack of standard of care. At that point, there hadn't really been innovation in treatments for melanoma. In decades, unmet need was very high. At the same time, if you recall our last webinar, I also used Yervoy as an example in France, and because of the early access to Zelboraf on the French market, Yervoy did not have as straightforward a path to reimbursement in France because Zelboraf and Braf had already become an issue for them. But when you look back at NICE, when Zelboraf starts being assessed, there are already considerations in the NICE Technology Appraisal Committee's comments, in the evidence review group's comments about BRAF as a subgroup, about indirect treatment comparison, about what the standards of care are, and differences in trial design and differences in patient population. And then really that second submission of Yervoy for first-line treatment of melanoma was where these things particularly came to a head. That's where you had to see very serious attempts by the manufacturer to conduct an indirect treatment comparison and meta-analysis to produce a comparison against Zelboraf in the BRAF mutation positive patient population. There was quite a lot of correspondence between the manufacturer, the evidence review group, and the technology appraisal committee in that instance. There's quite a lot of disagreement. You saw the manufacturer significantly altering their approach to the indirect treatment comparison to try to deal with the issue of exchangeability, which became very big in melanoma. Exchangeability is the issue with the similarity assumption. In particular, the patient populations in these trials are not comparable enough to be exchangeable. And what we saw was the emergence of a rejection of indirect treatment comparison in submissions for melanoma. At the submission of Tafinlar, this became even more pronounced. Crossover became a problem. The methods for ITC were much more heavily scrutinized and criticized. It doesn't take much to extrapolate from this to understand that this will probably be that much more so in the future. BRAF mutation status remains a key subgroup. Treatment history now becomes a key subgroup. as agencies start to consider BRAF inhibitor naive, PD-1 naive, Yervoy naive patient populations. This is going to become more pronounced. And the key question that comes out of this observation of a series of submissions that fell down on more or less the same point is why? How did these submissions continue to fail on the same question of the same type of evidence to be generated? It's the key question for us, and it leads us onto the path that can go out of this situation and help address these challenges. So this in particular goes back to the point I made about agencies that are more accepting of novel methods. In the specific case of melanoma, but many others, there are novel methods that will overcome this problem. It's not actually technically unfeasible, it's not actually insurmountable. And here are three of them. The first is called simulated treatment comparison. Simulated treatment comparison is the case when you, the manufacturer, have trial data, you have individual patient data, and you've got summary or baseline data for other drugs, because you don't have individual patient data for your competitors. That almost never happens. STC is an approach in which a series of predictive equations are constructed, and these predictive equations mathematically track and tell the story of a patient in your trial from recruitment, screening, randomization, treatment, onwards to the outcomes. With those predictive equations, you can adjust those for the baseline characteristics of another study, and you can effectively add that drug as an arm into your trial. And suddenly you've got individual patient data for all of the drugs you might need. It is as though you conducted a 6-arm clinical trial if necessary. 4 of those arms happen to have been simulated. This has quite a good advantage in that it gives you individual patient data. When it comes to subgroup analysis, when it comes to adjustments, you have total control over those factors. It has a disadvantage, obviously. Those predictive equations are not straightforward to produce, but if you have access to a well-specified clinical trial, it's certainly straightforward enough econometrics. The second is called matching adjusted indirect comparison, and the bullet point description more or less covers it all. You have your trial, you have individual patient data, you have baseline characteristics. As with melanoma, the characteristics of your patient population do not match that of another clinical trial, and you can't conduct indirect treatment comparison. You overcome this by reweighting your trial data so that it does appear like the trial that's been published. So rather than the simulated approach where you bring the other trial to you, your approach adapts your trial to the others. This has an advantage of being methodologically more straightforward. It has a disadvantage that you don't really have the IPD per se. And then the third is what's called meta-regression in a specific way, which is multidimensional network meta-analysis. And this is a regression-based approach which allows you to adjust not only for the natural history and prognosis, but also effect modifiers. So if you think about a model where you have regression coefficients in baseline survival and in the hazard ratio, and this can help overcome a lot of these challenges as well. And the reason why this is a particularly interesting example, as I said before, is that the MAIC approach was the one that was used for INLITA, accepted by PBAC and NICE, not accepted by Germany. And this is going to be an important consideration because these methods aren't going to be accepted everywhere. Some countries are potentially going to reject them outright, at least at the moment, because they're not part of the published guidelines. And some countries are just going to have more skepticism. So while I say that technically this is a strategy that can overcome these challenges, it means things like launch sequencing are also going to still be important. So those are the 3 main examples, and I think we have a bunch of questions which would be good because there's a lot of this to explore. What I want to come back to is a point that David had raised, which is what are our key takeaways this webinar, how do they correspond to the last one, with this idea that this is a very specific example of subgroup related problems. The key takeaway from this in and of itself is that you have to understand the intersection of subgroups and ITC at the level of the assumptions underpinning ITC. To us, this is the aspect of the methodological approach that doesn't get done well enough, and this is where failures occur. ITC is undertaken first. When subgroups have to be confronted, it's often too late or cost ineffective to go back over that. And this ties back, for those of you who here at the last webinar will recognize this slide, the early operationalization, the startup analysis, the idea that there is a piece of work and a proactive piece of work that should be done up front to understand what these challenges will look like. And in this case, that upfront analysis is not going to be as straightforward as the diagram on this slide, but conceptually it's not going to be that much more complicated. You know, you have a classical approach of a landscape study, treatment networks, ITC feasibility, you conduct the ITC, you have your model. Very early on, as we said in the last webinar, it's crucial to understand what your subgroups almost certainly are going to be. On that basis, re-explore that pathway. What you're going to find, some subgroups don't have a treatment network. Some subgroups do, but they will not have technically feasible methods, or they may, but you're going to have to consider what those methods are, and they may be different subgroup by subgroup. And then finally, you will find subgroups where everything connects. The data is very good, your evidence is very strong, and this loops back completely to our starting point, which is if this is the subgroup that has the strongest evidence, depending upon the delta that we're looking at, is this the subgroup that you should make your focus for reimbursement? This is the framework for consideration that helps you with investment and disinvestment. And then finally, the same points from last week is it's important not to hide from this. It's important not to hope it doesn't come up. It's important to recognize that these can be addressed opportunistically, and that understanding the subgroups and getting a subgroup strategy right early means faster launch with strong evidence, optimal reimbursed patient population across subgroups, optimal price, and best chance of retaining market share overall and in the face of reassessment. So thank you all for sitting through that. I'm going to pass back to David, and we're going to go through some of the questions that have come up in the last 40 minutes.
Thanks, Casey. We've got a number of questions that have come through, so thanks to everybody for sending those through. So we've got about 3 or 4 minutes for questions. Unfortunately, we won't get through all of them. Casey, I'm just going to take you back to a comment you made about the novel methods being appropriate for in the context of England, nice, but potentially rejected in Germany. So the question is, in this situation, what do we do about Germany?
Thank you. Yeah, so that's a fair point, the question of what you do about Germany. Going back a bit, I think it's important that it's not necessarily the case that novel methods will be accepted. I mean, like I said, NICE and the PBAC are more open and more forgiving. There will still be a point where evidence is too weak. For Germany, I think, yes, you should plan on the likely scenario that an approach like this won't be accepted. And the reason why it won't be accepted is because the IQWiG, the GBR requirements and expectations are very firmly on adjusted network meta-analysis using an appropriate comparator, either directly or for the connection. In MITRE is a good example. The matching adjusted indirect treatment comparison doesn't obey those rules. It's not an adjusted indirect treatment comparison. But you do see the GBR and ICWIC disagree, that I don't see any reason why any agency won't adapt to new methods. It's something that just has to be attempted and justified and well supported, because not trying this will mean that a submission is going to be rejected on that basis anyway in terms of benefit assessment. There isn't really anything to lose.
Good, thanks, Casey. I think it's important, the point you made, that what's not liked by ICWIC may be okay for GBR as well. So
yeah.
in 1 in 3 cases that they differ in their opinion. The next question is around as you think about trial design, what considerations should we bring in from a subgroup and ITC perspective? How would we go about that?
So I think one of the key issues for trial design, and this comes up for us a lot, is strategically, can you design your trial so that the comparator that you have best supports indirect treatment comparison? So certainly in oncology, but in a lot of other indications, there is a reasonable chance that you will have a 2-arm clinical trial. You will have direct head-to-head comparisons that some countries want and you won't for other countries. So you will have head-to-head evidence for some countries, indirect treatment comparison for some countries. And then the question becomes, when you confront that 3 years from now, will you have indirect treatment comparison for countries that accept that evidence or for countries that won't? And I think that can be one of the driving forces. You can think about, at the end of this, for whom will I have a strong network of evidence and how will they accept that? I think that can help you decide now which drug is the best to include.
Great, thanks, Casey. I think that takes us to the allotted time. Apologies to the attendees for the questions we were unable to get to. We will send a response after the webinar. Casey and I would like to thank everybody for their interest and attendance at this webinar. If there are any other questions or any other follow-ups, please feel free to drop us a note. Thanks very much.
Thank you, everybody.